Hello and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Zachary Schwartz. Today we'll hear from two HIV experts who will explore some of the nuances of managing HIV. We ask the question, how do you know if each person is on the right ART regimen for their needs? To follow along with the slides, see the link in the show notes. And to get access to all of our new podcasts, you can subscribe to the CCO Infectious Disease Podcast on Apple Podcasts, on Google Podcasts, or on Spotify. Now it's my pleasure to turn things over to our faculty.
Hello and welcome to this clinical care options session on peer perspectives, proactively considering if each person is on the right regimen for them. My name is Tristan Barber. I'm a consultant in HIV Medicine working at the Royal Free Hospital in London, UK, and I'll allow my co-faculty to introduce himself.
Hello, Tristan. I'm Roger Bedimo, Professor of Medicine and Interim Director of the Office of Global Health at UT Southwestern Medical Center and the Chief of Infectious Diseases Section at the VA North Texas in Dallas.
Great to be doing this session with you.
Now let's anchor this discussion on the following case. This is a 56-year-old cisgender man with HIV, virologically suppressed over the past 20 years on a regimen consisting of a boosted protease inhibitor. Now his current regimen is darunavir covistat FTC TAF single tablet regimen once daily. His past medical history is significant for chronic obstructive pulmonary disease, COPD, and a smoking history. In medications, he frequently needs steroids for COPD exacerbation during hospitalizations. He is amenable to starting a statin therapy after discussion with him of the recent findings of the REBRIEF study. On the right, you see in the table the patient characteristics. His CD4 count is 786. His viral load is suppressed below 50 copies per ml. His HIV subtype is B. Hepatitis B core antibody and hepatitis B surface antibodies show that he is not currently infected and he is immune. Hepatitis C antibody negative, serum creatinine is 1.1. LDL and HDL are respectively 98 and 46, and his BMI is 24. The question before us is this the best antiretroviral regimen for this patient? So I will have a discussion with my colleague Tristan about what our respective typical approaches to evaluating whether a person is on the right regimen for them is. Tristan, when you have this patient in your clinic, what thoughts do you have that will allow you to arrive at that decision, whether you think this is the best regimen for them?
Thank you. I mean, I think this is a great case. We continue to see a number of people who are on boosted PIs and have been for many years, sometimes without anyone taking the time to stop and think about why they're still on that particular regimen. Obviously, his current combination is a single tablet, well tolerated, with minimal impact on bone and kidney health from a tenofovir alafenamide perspective. But I guess we really need to think about why he's on a boosted PI overall. Does he have virologic reasons or resistance reasons in the past to need a boosted PI? Has our understanding of how perhaps second generation integrase inhibitors work for people with a history of virologic failure or indeed resistance, has that evolved? And so can we review the decision? And then I think it's obviously very important to ask an individual what the priorities are for them. Very often people have a lot of faith in regimens that they've been taking for a long time. And so I guess we really need to understand what his priorities are and how they interface with some of our medical concerns about him remaining on a boosted regimen for the long term. What about you, Roger?
Yes, I think I couldn't agree with you more. And we have here a person who has been living with HIV for 20 years. We have to assume that they've gone through a lot. They have had many changes in antiretroviral regimens. And sometimes when these patients arrive at our clinic and they are virologically suppressed, that could be something that they are very reluctant to change. So because they're now virologically suppressed on a regimen, even if that regimen is poorly tolerable, even if it is not convenient to them, they will be attached to it because it has, quote unquote, saved their lives. So our task is to constantly revisit at every visit whether that patient is indeed on the right regimen. And I will add to the fact that this is a 50+ person. As our HIV population is aging, comorbidities are added to them, and they start taking other medications for the non-HIV comorbidities. So at every visit, again, I repeat, we need to re-examine whether they are still on the best regimen, given these other medications that they may be getting. And this is somebody now with COPD exacerbations. Steroids, especially high doses used during exacerbations, may be a bit of a challenge in somebody on a boosted regimen. And now that, we are discussing him being on a statin, we need to understand that the levels of these statins may significantly be impacted by them being on a boosted regimen. So these are just two of the number of factors that we need to discuss with our patients who are aging with HIV disease.
I mean, the good thing about him is we've seen he's got a great BMI. I'm quite jealous of his BMI of 24 at the age of 56. So that's good. But of course, as you rightly say, we're worried about metabolic issues, prescribing for comorbidities, drug-drug interactions, and so on. So we really need to think about his general health and indeed his cardiovascular health. I was pleased that the discussion about Reprieve has already happened, because one of the things I'm finding crowds out some time to discuss antiretroviral therapy is discussing new evidence like the Reprieve trial. There's a lot to get into a short consultation sometimes. So Reprieve is an interesting one, but he's already accepted a statin, so that's good.
Wonderful. So now this is WHO Global Health Sector Strategy on HIV 2022 to 2030. The WHO strategy calls for a more precise focus to reach the individuals most affected and at risk of HIV and AIDS, to address inequities as they prevent the world from ending the HIV and AIDS epidemic. So let's look at the least reached people. A more holistic, people-centered HIV care approach focused on long-term well-being is needed to address the following issues: health-related quality of life, multi-morbidities, as we discussed earlier, examples, non-communicable diseases and mental health, as well as addressing stigma and discrimination. So these are the 5 pillars to support the vision for long-term success for people living with HIV. So number 1, getting viral load to undetectable level was identified as a primary treatment goal. And the desired outcome, of course, is a sustained undetectable viral load. So this is the first and foremost thing. The second one is treatment-related factors and excessive clinic visit were identified as the most notable burden of living with HIV. So minimal impact of treatment and clinical monitoring are important. Number 3, maintaining quote-unquote optimal health-related quality of life was also identified as an important goal for people living with HIV. Number 4, consistency of care among different healthcare providers was also identified as a key factor on improving healthcare outcomes. So lifelong integration of healthcare is important. And I will editorialize a bit on this. People with HIV receive care for the non-HIV conditions outside of the HIV clinic. It's really important that we coordinate care with all those other services. Finally, stigma and discrimination were also identified as key barriers to achieving optimal health outcomes for people living with HIV. So now we look at, so do we currently have a systematic way of proactively assessing ART challenges for our patients? And I'll go back to my friend and colleague, Dr. Barber.
It's a really good question, isn't it? I don't know about you, but I think this is done in very different ways, in very different clinical and geographical scenarios. I think we probably don't have a systematic way of addressing this in our own cohort. We do have a wellbeing review clinic that we allow people who are over 50 to opt into, or we suggest it as a replacement for a routine visit, so they can have a full comprehensive health assessment about things that are not just HIV related. But even in that, I don't think we particularly ask specifically about issues around antiretroviral therapy. I think what I've experienced in the last year or so is that it's really important to have a very non-paternalistic approach to discussing novel antiretroviral therapy options. For instance, when discussing injectable antiretroviral therapy, I've been surprised how many issues this has sometimes uncovered in people that I'm seeing, touching on some of the pillars you've already mentioned, sometimes issues around stigma, discrimination, domestic violence, in the past, and actually being able to have a method of antiretroviral therapy that doesn't need disclosure to household or intimate contacts can be really liberating for some individuals. I think for other people, obviously, side effects of antiretroviral therapy change over time. We know that side effects may change with aging, may change with other comorbidities and change in social circumstances. And so I think sometimes it's just important to take a step back and make yourself realize that it's important not to make prejudgments about how people might be feeling about their treatment or what they might be thinking about the approach to novel antiretroviral modalities. So I guess my biggest lesson around offering switches in recent times has been really making sure that I'm not allowing my own prejudgment to come in the way of really trying to understand what's important to an individual in front of me living with HIV. What about you?
Excellent. No, thank you. All I want to add is that we should always assume that there will be ways to optimize the regimen of that the patient is on, not just because that patient has been virologically suppressed doesn't necessarily make it the best regimen for them for all the reasons that you have brought up.
Was just thinking about the fact that a lot of guidelines are starting to suggest that we do use things like patient-reported outcome measures in assessing people, maybe at least annually. But I think at the moment, what can be confusing on the ground is there's often no clear guidance as to which PROM is really best, which PROM is the most helpful in managing people living with HIV. So I think we will see the introduction of more systematic ways to proactively assess antiretroviral challenges. But at the moment, I get the feeling that people are doing it in quite differential ways, depending on where they work and who they see.
Yeah, this is an excellent introduction for what we're going to discuss next, i.e. tools to proactively evaluate treatment satisfaction and adequacy for the patient. Clinic ready apps, web-based symptom collectors. This is the digital age. There's a number of things online that could be helpful for the patient's readiness for change scales, and multidisciplinary team reviews performed at regular intervals. For instance, nurse and or pharmacy-led interventions. We like to think of HIV care as a team sport. That sport is played by clinicians and non-clinician staff, physicians, advanced practice providers, pharmacists, social workers, and all these people should be brought to bear in understanding how we can optimize the patient's life. So I think we'll get back to the same patient that we discussed earlier. So Dr. Barber will take over the discussion about other aspects that we may want to consider. This is still the 56-year-old cisgender man with HIV, virologically suppressed, and now on a darunavir-cobicistat FTC TAF regimen, but also with COPD and interested in a stat. So, Dr. Barber, take it over.
So we might think about the following reasons to consider regimen optimization in the setting of viral suppression. We might consider simplifying someone's regimen by reducing their pill burden or reducing the dosing frequency. We might try and enhance tolerability and also try and decrease short or long-term issues around toxicity. I think this is really where our ethical imperative sits as HIV clinicians, that not only do we have to think about the immediate viral suppression goal, but also we have to think about tailoring antiretroviral therapy, particularly as people age, to make sure that they're having the best health-related quality of life as things change and evolve. We may want to prevent or mitigate against any potential drug-drug interactions. We may want to eliminate food or fluid requirements that people have with taking their medicine. And as I've mentioned, we might want to think about switching to a long-acting injectable regimen in certain individuals to relieve pill fatigue or to decrease potential stigma or disclosure concerns that may be associated with taking daily oral medications. Of course, when we're looking at someone who is pregnant or maybe thinking about becoming pregnant, we want to think about the optimal use of approved antiretroviral therapy according to our own guidelines for the use of antiretroviral therapy during pregnancy at that particular time. And in certain situations, we may want to think about ways that we can reduce cost whilst continuing to maximize benefits for an individual living with HIV.
So here is just one of the tools, and this is HIV Assist, and it looks at weighing a score that looks at different aspects of the regimen that the patient is on. So as you can see here, the patient is coming in at no resistant associated mutations and no comorbidities, and is taking atorvastatin and prednisone. CD4 count is over 200, and virologically suppressed. So HIV Assist walks you through several aspects of looking at adequacy of treatment. You can see the regimen listed there, and then the way they score, number of active drugs in that particular regimen, the total pills that regimen contains, and then the frequency of using those drugs. So what you can see here is that you can evaluate looking at the sheet for people like this patient on darunavir cobicistat FTC TAF. And then you can look at the change in score by whatever intervention you take or that change that you make. So you can see that this somebody is virologically suppressed. The modified base score, similar regimen with similar or better pill burden and number of active drugs. You can see here one. And then you can look at the pill burden. Regimens with higher pill burden exists, and the frequency to receive higher penalties. So if you have a higher score, it's a higher penalty. And then you look at mutations. You can get these from the Stanford database. And then co-medications. Now, we have already mentioned these two aspects for our patients. The co-medications that this person may compromise the antiretroviral regimen that he's on is using steroids and statin. And we have to put a score of +1 and +1 for each one of them, because he may end up needing them or using them. So he has now a score of 3, which means that there are significant opportunities to optimize this person's regimen, because higher score means higher opportunity to optimize. Tristan, how would you optimize this person's antiretroviral therapy?
Wow, it's a big question, isn't it? I mean, I'm going to certainly talk to him about what's important for him. I'm going to need a little bit more information about his virologic history and any resistance mutations. My gut feeling is that I would like to get this man off of a booster, if possible. I'm thinking about prescribing for the future. I'm thinking about the potential impact of being on a boosted PI on his lipids, perhaps despite having a statin on board. And so I'm going to talk to him about whether oral treatment is the right thing for him, whether he's suitable for, or whether he'd consider injectable therapy. If there is a resistance history, I might be thinking about which second-generation integrase inhibitor I could use, depending on what the resistance mutations look like. But my gut feeling is that with modern agents, for most people, we will be able to look at a combination that doesn't involve a boosted PI. And some people we can't. Some people virologically still need a very high genetic barrier regimen based on a boosted PI, and we understand that. But I think with the evolution in our knowledge, particularly around second-generation insties, I think it's highly likely we'll be able to create a new regimen for him, and one without the metabolic toxicities and the potential for drug-drug interactions that he has currently.
No further comments. I think that this is exactly what I would do. So I think you can take us home with the best practices.
Well, I think that's really kind. I think we can look finally at the bullet points on best practices for antiretroviral optimization, some of which I think we've covered very well during this discussion. Number one, we must center the patient in all competing priorities of the healthcare team. We all have our own thoughts about what's right, but really we must center individuals and make sure we understand what's important to them. We need to proactively address social determinants of health with an emphasis on stigma and discrimination. I think there's special emphasis to this if the attendance to clinic is suboptimal, which may be for a number of factors. We need to think about whether non-HIV comorbidities are optimally managed. We need to, of course, regularly monitor HIV viral load and consider if the antiretroviral regimen is optimal, even if there is viral suppression. Simplification can be important. This may include a non-paternalistic offer of long-acting injectable therapy. We need to review tolerability. Some patients have endured side effects from older regimens and may be reluctant to change because they place so much trust in those regimens, and it's up to us to explain to them why it can be safe to change and may improve their health-related quality of life. And of course, using our MDT as well, we need to review potential DDIs with non-HIV medications, and specialist pharmacists, of course, can be invaluable here. And we need to pick up on our opportunities to consult with or refer to other members of the multidisciplinary team, including, as mentioned, our pharmacists, but also social workers, nursing staff, peer support workers, and many other members of our MDT that may vary according to where we work and how our healthcare systems are structured.
Thank you, Dr. Barber and Dr. Bedimo, and thank you to our listeners for tuning in. To learn more from this program, see the link in the show notes. We'll see you on the next podcast soon.